And Dr. Ajay Aurora has also joined us now, and he will be talking about diabetic macular edema. We have tried to make this instruction course interactive so that on one hand we discuss etiology and on the other side we discuss some clinical things so that it becomes more useful and interesting. The idea basically has been again taken from JV sir. He is a fatherly figure for all of us in retina and uvea. So Dr. Ajay Arora, yeah.
For the connection. So thank you, Dr. Malay, for including me in this lovely program.
So till he is getting things done, Dr. Darayos, what's your take on doing treating peripheral neovascularization? How much importance you give to peripheral NV?
This is with regard to which
that
subset
uveitis patient you showed extreme
Yeah,
periphery.
I think it's always good to treat it because it's so far away in the periphery. There's nothing to really lose. So I think we treat it. Other very interesting cases which I'm very interested in is a PHCR, peripheral exudative hemorrhagic chorioretinopathy. That's something we've worked a lot on. So those cases also, the standard of care is to observe, but I do find that if there's a large mound, especially one-eyed patients, you give anti-VEGF, and then you do imaging, and if you find the CNVM in the periphery, you can laser that also. So I think peripheral laser is something which is really safe and long-term for our patients.
One small comment from Dr. Manish. Already I think that question has been answered, but suppose if you have a peripheral, how much importance you are giving to peripheral NV with reference to diabetic retinopathy? Dr. Aurora, you can also step in.
Reference to diabetic retinopathy.
Yeah.
Diabetic retinopathy, sir, mostly we get mid-peripheral.
Let me qualify my question. Earlier we were looking into that mid-periphery thing, but I think SN guy, Dr. Raman, Rajiv Raman, he has talked about a lot about going into the periphery and looking into for neovascularization, especially with the newer technology. How much importance do you think you give to that neovascularization?
Sir, still when the patients land up to us, we have to treat NVE, whether mid-peripheral or peripheral. If diabetic patient is developing NVE, we have to do the lasers. There is no question about it. But my question would always be, always be skeptical for the branch retinal vein occlusions for other conditions like vasculitis, where there are a lot of collaterals develop actually. So these collaterals actually, even if a large CNP is present, they will not transform into an NVE unless it is very, very periphery, which is the watershed zone for the retina. For these conditions, vasculitis, BRVOs, the periphery small CNP will develop NVE, whereas a large vessel block will develop more collaterals and is unlikely to develop NVE. Diabetics, because it's a progressive disease, if you see an NVE, you will have to treat these patients anywhere they are.
And Malay, in cases where we've had patients who have recurrent vitreous hemorrhage, we have operated, we have done a vitrectomy, we have lasered, and then you do a wide field angiography in these cases, and you find that you had actually not lasered completely, and you had left off some small front which needs to be lasered. So that is the importance of NVE. And coming to what you mentioned about BRVO cases, so we have had 2-3 cases which I'm just going a little offshoot, where you have areas of capillary non-perfusion in the periphery, collaterals are developed. So in these cases, we have done a micropulse to the periphery without lasering them, without altering their field, and we have kept them stable for about 2 years. So thank you, Malay, again. I'm talking about DME current concepts in clinical management. So I think this is the basic diabetic macular edema, that is a multifactorial condition, that it causes visual impairment that critically impacts the patient's quality of life. And we all know about the classification of a clinically significant macular edema, which you should still, for the exam going PGs, it's important to know how do you define CSMA. And then the DRCA.net and the European expert panel came up with a center involving diabetic macular edema and a no center involving diabetic macular edema. When you have a focal edema which doesn't involve the center, you should treat them with laser, while if you have a center involving diabetic macular edema, you treat them with pharmacotherapy. This is a busy slide, but I think you should learn about what are the pathways involved in pathophysiology of diabetic macular edema, because that helps us in finding their treatment. This was a patient who had come to us with, this was many years back, and then this patient had both eyes clear-cut defined diabetic macular edema, OCT demonstrated it, but patient refused to take any intervention, went into a holistic way of handling himself, did yoga, did a good dietary control, and this is what it was 6 months later, which clearly shows that a good dietary control and managing your diabetes well could help. Metabolic control is extremely important. This patient came to me in the OPD in a multi-speciality hospital, where patient presented, patient underwent dialysis, and patient's diabetic macular edema resolved. Again saying that metabolic control in a diabetic patient is extremely important. This was a patient who had thalassemia with a hemoglobin not going above 9. So we treated the patient with, we could not get the anemia treated, was treated with anti-VEGFs, and subsequently this patient, this was way back in 2008, 2009, it's almost about 15 years back. We went ahead and did a vitrectomy where there was no traction, which probably improved oxygenation to the macular area, and patient did well. And it's now been demonstrated that once you do a vitrectomy in these cases, macula becomes a little better after you have done all other methods of treatment. Focal edema, which should be treated with focal laser without giving any anti-VEGF, so that is again important. You don't have to give anti-VEGF in every patient. When you have an extrafoveal edema, you can treat it with focal laser. Must do an angiography before that. This is just standard giving anti-VEGFs. Patients respond. This was a patient who was 52-year-old diabetic with a hemoglobin A1C of 7.2. Diabetic macular edema. We could not make out the the outer retinal area very clearly with the OCT. Went ahead and gave Avastin. The architecture of the OCT improved. Patient received multiple injections, and patient did well eventually. Whenever you have a tractional diabetic macular edema, these patients need to be operated. And these patients, we can't keep pumping them with intravitreal injections. Identify the tractional process and treat them with surgical intervention. Now comes the point of what is the role of inflammatory factors, and it's been shown that other than VEGF, there are other factors like ICAM, IL-6, MCP1, all these are involved, and they are important as far as diabetic macular edema goes. So these are some of the biomarkers like the hyperfluorescent diffuse diabetic macular edema. You have this hyperreflective spots, the cystoid changes, the neurosensory detachment, and the increased thickness of the inner retina. This is a very nice graph, which actually a table which shows which patients with what findings will respond to the first line anti-VEGF treatment or the first line steroid treatment, and if you put these all together, you can actually treat them with your choice of agent. How do steroids act? They have an anti-inflammatory as well as an anti-VEGF injection. So this was a 57-year-old female, type 2 diabetic, hypertensive, pseudophakic, who obviously had this macular edema with cystoid changes, with hyperreflective spots, was treated with Ozurdex. This is 6 weeks post Ozurdex. The macular edema had reduced. Initially, the patient got anti-VEGF, but subsequently we treated the patient with steroids, responded well. This is an old slide of mine. This was in Chandigarh, where we had treated the patient with Ozurdex. Patient did well. So now is something which I'm using very limited Ozurdex now. I do use, but most of my thing is treated with a suprachoroidal injection of triamcinolone. You can see here that and now we have started using centrifuged triamcinolone. A single injection of triamcinolone given in the suprachoroidal space lasts us almost for about 6 to 7 months, which is, I don't think any other agent gives us that. So this is a lady, and this was my first patient who had come to us when Ozurdex was for some time not available in the country. It was an obese female, had received multiple injections of anti-VEGF and had also received 4 injections of Ozurdex in each eye. You can see here that there's a persistent diabetic macular edema. So we went ahead and gave her suprachoroidal triamcinolone. You can see this is the response on the 14th day, 34th day and 70th day. So about this effect lasted for about 88 days. Now with the centrifuge triamcinolone, the effect is much more. The other modality that I'm using in our center is a micropulse laser, and there are numerous studies now which show that micropulse laser can be used in conjunction with anti-VEGF. We normally decrease the macular edema to a level of below 450 or 400 microns. Then we go ahead and do the micropulse laser, and we found that number of injections to an extent can be reduced. And it's been shown by the microperimetric studies. We don't have a microperimetry, but it's been shown that the visual field of the microperimetry is maintained as compared to a conventional laser. So this was a patient who had received micropulse, and right in the early days, and patient did well. This is another patient who had micropulse laser followed by cataract surgery. Patient did well. This is a patient with a persistent diabetic macular edema. So sometimes you keep on injecting and the diabetic macular edema persists. So these cases, it's a good idea to do a wide field angiography, and you'll be surprised to see that you have NV in the periphery. Go ahead and laser them. Once you laser them, your need for giving intravitreal injections would reduce. So that's what happened in this particular patient. Patient responded well. So these are the biomarkers which correlate visual acuity with OCT and DME. The central foveal thickness correlates in about 27% cases of DME with visual acuity. Then you have drill, you have ELM integrity, ellipsoid zone, which is formerly called the ISOS junction, thickness of the photoreceptor outer segments, and the presence of subretinal fluid. So this has been well documented that if you have which patient would do better, patient who has maybe the macular thickness is the same. If you have a drill, obviously those patients will not do well, and drill can be predicted. You know, it can resolution of it can be predicted about 8 months in advance. Retina has given us very good guidelines of managing diabetic macular edema. So when you have a major cardiovascular event, you should use a corticosteroid. If you have a tractional macular edema, you could again use corticosteroids or anti-VEGF. And otherwise, anti-VEGF is still the primary drug to be used initially, followed by steroids. As I gave you the chart, that is very, very useful. If you follow the chart, we could definitely ease the decision-making process. So, because of paucity of time, Ajay Dudani has come here to make a talk, so I'll finish off fast. Please remember that if you do a cataract surgery in a patient with a diabetic macular edema, please treat a diabetic macular edema well. If you do cataract surgery in such a patient, you might end up in such a situation which becomes a medico-legal issue. So the key take-homes in the end is a good metabolic control with control of anemia, lipid control. Anti-VEGFs are the first line of therapy. Steroids have a significant role to play. Intravitreal corticosteroids act by their anti-VEGF property and block the inflammatory mediators. DEX implants are effective and show a favorable clinical response. We've had a very good response with suprachoroidal steroids, and they are cheap. They are effective, and they have a higher durability than Ozurdex implant. Traction diabetic macular edema needs to be operated. Focal edema needs to be lasered, and you need to do a supplemental laser to NV and capillary non-perfusion area. We have done few cases of micropulse laser, and it's showing its additive effect to the anti-VEGF agents. Thank you very much.
Great, great presentation, Dudani. I'm
my Dr. Ajay.
Oh, sorry, Ajay Aurora. both are Ajay.
Yeah,
So as your presentation was moving, I had so many questions, and you actually have already answered all those questions.
Okay.
So that's great about your presentation.